Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. Thank you for joining the We Can educational series. Today, Dr. Ann Budzak will discuss medical child abuse. The handouts area includes a PDF of today's slides, as well as a PDF with details on the following housekeeping items. To ask a question, you can use the question pane on the control panel. Questions will be addressed at scheduled breaks. To obtain continuing education credits for today's session, you must track your attendance by texting today's code to the phone number on the screen. The code and phone number will be displayed at the end of today's session. After reporting your attendance, you should log into your account at ocpe.mcw.edu and complete an evaluation within 10 days. To view step-by-step instructions on claiming continuing education credits and to see a list of future webinar topics, please visit wichildabusenetwork.org/webinars. Now we will proceed with today's presentation.
Thank you, Elizabeth. Hello, everybody. This is Ann Budzak, and we're going to talk about medical child abuse today. I want to start by saying that I have nothing to disclose. And let's review the objectives for today's presentation. First, we'll define what medical child abuse is. Next, identify some of the similarities between medical child abuse and other forms of child maltreatment. Go on to describe what to do or how to proceed if medical child abuse is suspected. And then close by distinguishing medical child abuse from medical neglect. So let's go ahead. What is medical child abuse? A child is considered to be medically abused if they are receiving unnecessary and harmful or potentially harmful medical care at the instigation of a caretaker. This used to be called Munchausen syndrome by proxy, which referred to the more extreme forms of medical child abuse, where the caretaker often inflicted factitious illness or created it in the child for their own gain. But really, currently, we prefer to call this medical child abuse rather than Munchausen's by proxy because it's broader than that. It's really a child who's receiving too much medical care, and that care is being driven by the caretaker. So it's really a spectrum from overutilization of medical services for minor problems to fictitious illness created by the caregiver by injecting bacteria in the bloodstream or other substances, creating factitious fevers, etc., which is the more extreme form. So what does this encompass? Well, like other forms of abuse, it ranges from mild to severe. It may be numerous unnecessary trips to the pediatrician. If we think about our own practices as general pediatricians, we all have a certain number of families whom we may think of as quote unquote frequent flyers. They tend to have a much lower threshold for seeking medical care for their children than the average parent. When this becomes extreme, it really is a form of medical child abuse. When there are unnecessary trips to the doctor and reports of symptoms by the parent of the child That can lead to unnecessary diagnostic tests, blood draws, x-rays, CTs, MRIs that might not really be needed. Repeated examinations happen every time the child is brought to medical care. Within child abuse pediatrics, I certainly had a few examples of families that kept bringing their child for sexual abuse exams, their young toddler, when no such abuse had occurred. But because of the parents' own anxiety and past history, they were convinced that we were missing something. At some point, numerous child abuse, sexual abuse exams becomes very inappropriate, unnecessary, and would qualify as child abuse itself. Explaining that to a parent takes lots of time and patience, but is very important when you recognize that that might be what's happening. Too many doctor visits means often numerous specialty visits and prescribing of unnecessary medications to try to treat this fictitious illness. Unfortunately, some children go on to having minor or major surgery that's unnecessary, such as placement of a G-tube for inability to eat by mouth, as reported by the caretaker, or even more invasive things. So the risk of harm really also ranges from mild to severe, like other forms of child abuse. An example of mild harm may be missing days or weeks of school because of all the doctor visits that the caretaker brings the child to. Severe harm may be death, and about 6% of these cases do result in a child fatality. The risk of escalation of the severity of harm really varies, just like other forms of child abuse. Mild harm does not predict or ensure that left undetected, it will escalate to the demise of the child. It may stay at a lesser level until it is recognized for what it actually is. So medical child abuse is one form of child abuse, and this form occurs within the medical care environment. And so it involves us, the providers, and is really something which most of us find very odd and unusual. Because it is unique, it is tempting to really get caught up in why the caretaker is doing this and focusing on what causes the caretaker to inflict or fabricate serious illness in their child. But really, for us as child abuse pediatricians and providers, we need to focus on the need for protection of the child rather than the motivational cause by the perpetrator. So how do we recognize this? It isn't easy. Some of the more common complaints in cases of medical child abuse are recurrent seizures, prolonged or recurrent fevers, apnea episodes, intractable vomiting and or diarrhea, Usually, these are problems that never seem to respond to traditional treatment and never seem to get better. Or they get better based on treatment for a very short period of time, and then it's back again, or there's a new chronic problem. Often, these children have very complex or extensive past medical histories because the parent has been seeking care for these problems for a long time. And they may already have seen numerous specialty providers by the time you see them. Sometimes the child starts out with a legitimate, real medical problem, but that problem passes and then the fictitious problems begin. How do we identify this? Well, there are some perpetrator characteristics that may or may not be helpful. The perpetrator is more commonly female than male. This may occur in a two-parent family. And if there are two adults in the household, or more than two adults, the others are usually supportive and defer to the decision-making of the perpetrator. So if the mother is making the decisions for what kind of care the child needs and reporting the symptoms, the father or significant other will be supportive and agree that what the mother is saying is indeed true, whether they've seen it or not themselves. The other interesting characteristic of the perpetrators is often these folks have sought unnecessary care for themselves as well, and they tend to be people with multiple somatic complaints. Probably the most consistent characteristic is that these families put a very high value on somatic symptoms and medical treatment. So these are not folks that ignore any little thing. They run to the doctor for any minor problem and put a lot of value on obtaining the doctor's opinion and receiving treatment. They expect to receive treatment. So the provider, us, become the vector for the abuse. We are not the perpetrators. We don't immediately recognize these cases very often, and we depend on parents to obtain a medical history for young children. This is how pediatrics works. Children can't speak for themselves in the first few years. Or for some children with disabilities, they may never be able to speak for themselves. The symptoms that we are told may be embellished or fabricated, and generally we trust parents. We believe what they tell us. We believe they know their child best. And so, although it's our job to take a thorough history and ask appropriate questions, asking people if they're lying is not typically part of a routine medical history with the average patient encounter. We tend to be nice folks. We tend to be empathetic. Our job is to support parents in their care of their child. And so we enter into this without realizing that the case of medical child abuse is unique and not like other families. So you could ask, does that mean that the provider's at fault? And certainly when providers realize what has been happening, they may feel very, very uncomfortable and very bad that they ordered any tests or prescribed medication or were sucked in to this fabrication. But really, you can be assured that your care was appropriate if the care that was offered in good faith, the care was consistent with the community standard of care for any child with the presenting symptoms you were given, if other physicians would have given the same type of care, given the same circumstances, and because there's a basic assumption of trust between the provider and the parent. The care is inappropriate not because the provider provided inappropriate care, but because it was based on lies, on falsehoods. The care was appropriate for what the provider was told. So what do you do when you realize that you may have been a part of this perpetrator's attempt to abuse their child? Well, the very most important thing is to go back to the 5 basic steps in child protection first. Identify the child who's being harmed or is at risk of being harmed. Stop the harm. Ensure the harm won't resume. Treat the physical and psychological consequences of the abuse for the child. And try to maintain the integrity of the family unit as best we can. So this is no different at a basic level from any other form of child abuse. The child is felt to need protection from their caretaker, and sadly, there are long-term consequences psychologically to the abuse for the child. If we look at adult survivors of this type of abuse, they have an increased risk of depression, anxiety, drug and alcohol abuse, difficulty with relationships, just like survivors of other forms of child abuse. Why don't we pause there and see if anyone has any questions?
No questions right now.
Okay, let's go on. So now that we have a sense of what it is, how are we going to know it when we see it? There are certain things we can ask ourselves as providers that may give us a clue that we're thinking in the right direction. First and foremost, does the history provided by the caregiver match what you see when you look at the child on exam? Secondly, does the caretaker or parent seem to have an agenda? Certainly some families, when they come to see us in the office or when they're admitted to the hospital, have their own plan in mind, and they make it fairly clear to the provider that they have certain expectations for what is going to happen. Lastly, ask yourself, do you as the provider feel uncomfortable or pressured regarding these expectations for care by the parent? And if so, medical child abuse may be what's happening. One of the biggest clues to discovering a case of medical child abuse is that the child is symptom-free when they're not with the parent. In other words, these complex, difficult, sometimes life-threatening symptoms reported by the parent or seen stop happening when the child is not with the caretaker. In very complex cases, There is sometimes thought to be a role for video surveillance in the hospital. This is not routine. This is not maybe even available in your hospital, but it certainly has historically been used to try to uncover whether the parent is actually perpetrating the symptoms when no one is thought to be looking. So when you feel that you may have a case of medical child abuse, then it's time to take the next step. If the exam doesn't match the history, or if the previous care received before the child saw you seems extremely excessive, if there's a complicated, extensive past medical history, then it's time to sit down. It's time to obtain records from every facility that this child has been seen at and go through the records page by page by page from all the different specialists, all the different facilities, and try to put the pieces together and see if it makes any logical sense. Now, this is incredibly time-consuming, as you might imagine. So this is where a child abuse pediatrician can be extremely helpful and may be the ones, when consulted, that can put the pieces together and see what they add up to. And I would encourage consulting a child abuse pediatrician at that point. So one of the things we know about medical child abuse is that it is hard to diagnose, and it is often missed. It can take anywhere from 14 to 24 months to make the accurate diagnosis of medical child abuse. And the biggest reason is because the provider didn't consider the diagnosis of medical child abuse in the differential diagnosis when looking at the symptoms. So how can we get better at recognizing it when it's in front of us? Well, Dr. Mary Grainer, along with Vince Pelusi and Brooks Keeshan, created a medical child abuse screening tool in 2013. Their goal was to try to make it easier to recognize potential cases of medical child abuse by coming up with a list of characteristics of a family that might trigger consideration of a medical child abuse diagnosis. They looked at children admitted to the hospital with seizures, apnea, or recurrent vomiting and diarrhea. They reviewed cases of confirmed medical child abuse and came up with a list of criteria that were common to most. Their suggestion was if a screen was positive, then a referral to child abuse pediatrics should be made. Here is the list of symptoms and signs that they came up with. And the screen was considered positive if a family had 4 or more of these 15 criteria. So they include the caregiver themselves having features of their own Munchausen's, the caregiver being under psychiatric care, the caregiver having a personal history of child abuse, the caregiver wanting to leave the hospital against medical advice or insisting on a transfer to another institution, the child having a history of cyanosis, the child having a history of being seen at more than one hospital in the previous 6 months to admission, the child having had consults with more than one subspecialist in the past, the illness abates when the child's out of the care of the primary caretaker, the child having had more than one episode of apnea since discharge from the newborn nursery, bruising or trauma to the face or neck of the child, a prescription or request for an apnea monitor by the family, a child having chronic diarrhea with or without vomiting, or chronic vomiting and diarrhea without a definitive diagnosis. If the child has a history of erratic drug levels or toxic drug levels on more than one occasion. So 4 or more of those should trigger a consult to Child Abuse Pediatrics to consider whether medical child abuse could be the cause of the admitting symptoms. So let's say that we do that and come to a point where we believe that that is indeed exactly what's going on. What do we do next? A care team meeting is critical to moving forward. So these children often have several providers in different subspecialties at the point where a diagnosis is made. And so bringing all of the providers together to sit down and discuss this finding is critical. Everyone needs to be on the same page. Everyone needs to be in agreement that this is what's actually happening. Sometimes 1 or 2 of the providers may feel that there is still some specific necessary tests that must be done in order to be sure that other possible entities are definitively ruled out. It's critical at the time of diagnosis of MCA to stop the most invasive care first, whether the child has central lines or a G-tube or whatever that is, to put a stop to that as a first step. And then moving forward, a care plan, a plan of medical treatment needs to be created and agreed upon by all of the providers on the care team so that everyone knows what's happening, everyone knows what the plan will be. Next, a sit down with the family is required. Both parents should be present, as well as any other family caregivers that might be involved with the child. The more of the child's medical providers that can be present for this meeting, the better. As often, the family may try to play one provider off another. And so everyone being present at the same time is extremely helpful in devising a plan to move forward. It's also very helpful if one provider is appointed to be the gatekeeper for future care, so that playing one provider off another is less likely to occur. If your institution has nurse managers, case managers, this is the type of family who can benefit from case management, care management. Then there is a go-to person that the family can call for every concern that they have going forward, and they will have many. It's important that the family have access to someone they trust as they adjust to a new way of care. They need to be able to call and ask questions and verify that their concerns are heard and that they are acknowledged and that there is a plan. It's also critical to set up scheduled visits once the family leaves your office or the family leaves the hospital. They need to know when they're going to come back. And they should come back initially on a very regular basis to discuss any concerns ongoing, to discuss any new concerns they have, and to provide reassurance that they are being cared for, and to reinforce the new care plan with them over and over. If there are community supports available that can assist the family, this is the time to arrange for that. If the child is school age, it's critical that school also know what the plan is. They have been told up to this point that this is a fragile, chronically ill child. And so again, the approach may be very different going forward, should be very different going forward, and they need to be a team player as well. It's clear to all of us that the perpetrator, the caretaker, would benefit from mental health care. That may not be something they're receptive to. And in fact, I haven't found that any of the cases I've been involved with that they were receptive to that. The child clearly will also benefit from mental health care and support. Remember that depending on the age of the child, this may have gone on for quite a while, and the child may perceive themselves as medically fragile. They believe what their parent has told them about themselves. And so having the child now be told, well, that's not how it actually is a very difficult thing and will require the assistance of a professional mental health provider. Ongoing care is going to be important as the child grows up, similar to other victims of different forms of abuse. When should CPS become involved? Well, when the level of harm or potential harm requires immediate separation of the child from the caretaker, clearly CPS needs to be involved. The other time is when the caretaker refuses to consider the new care plan and insists that the child needs to maintain their former level of care and may insist that they are firing you and all of the other people on the care team, and they're going to take the child and go to a different institution and start all over again. CPS then needs to become involved. Why is something we all ask ourselves, and because we try to understand people and it's our nature to want to help. Frequent utilization of healthcare is often a symptom of parental anxiety. As I mentioned before, the child may have had a true medical incident or problem, and this creates an identity within the family of medical fragility. The child may be absolutely fine going forward, but a fragile child has been created in the minds of the family members, and that child is treated differently. Remember that for some parents who are isolated or feeling isolated, they may get huge secondary gain from medical visits. I have observed the evolution of a family of one of my partners who had a child with some disability who created a whole life around coming to the office as often as possible for multiple minor complaints that didn't require medical care. These are the folks who get to know everybody in your office by first name. They will sit and chat with the receptionist, the medical assistant, the nurses. They want to know about their families. And it's very clear that the trip to the clinic is a social outing for the parent. Remember that different families interpret and deal with illness differently. And so frequent overutilization of healthcare may be a learned pattern of behavior that is based on how the parent was raised when they were children. I have a family that was in my practice for many years and took care of a little girl who over the years saw me more often than most for many minor things. She grew up, she had her own 2 children, and guess what? She is doing the exact same thing, only her level of doing it is even higher as she is certain she's seeing seizures in one of her children, etc. But as the older provider who cared for this mother as a child herself, it is not a surprise to me that this has evolved. Unfortunately, it's now at a more severe level as she is an adult, but it's easy for me to look back and understand how this type of functioning evolved. Remember too that unfortunately at the end of the day, just like with other forms of severe abuse, this may be malicious behavior on the part of a caregiver due to their own mental illness. Let's stop again and see if there's questions.
Yes, a couple questions. On
Okay.
the medical child abuse screening tool, I could see a medically complex child legitimately having 4 of those symptoms. Can you speak to that recommendation for a referral to a child abuse pediatrician?
I think that there's more to it than just ticking the symptoms off the list. There's also the question of, do you feel that the specific child with complex medical problems is different from other children who have complex problems as far as the behavior of the parents, the reasons for seeking medical care. If it seems no different than any other family, then, you know, there's no reason to go down that road. But if you feel in your gut that this family has an agenda, this family wants specific things, this family is here 50 times in 3 months instead of once in 3 months, this family is not getting similar results to the care that other families, children with similar problems sees by and large. I hope that answers the question.
Great, thank you. And why is cyanosis a flag?
Cyanosis is subjective as well as objective, depending on who is seeing it. A parent who is reporting seeing cyanosis recurrently may or may not be seeing it. And if you never see it and other Caretakers, while the child's in the hospital or the office, never sees it, but the minute you step out of the room, it happens, and then it won't happen again until everybody's gone. It's a reason to think, is it really happening?
Great, thanks. That's all for now.
Okay. Well, let's end by briefly talking about medical neglect, which is essentially the opposite of medical child abuse. In medical neglect, a child doesn't receive needed medical care at the discretion of their caregiver. They get too little care instead of too much. They don't comply with care that's been recommended, or they don't seek care when other families with a similar situation would seek care, and that lack of care must cause harm in order to qualify as medical neglect or cause the potential for serious harm to the child. Now, again, we're talking about degrees of care and compliance. Most of us as pediatricians feel that attending well child care visits and receiving recommended immunizations is appropriate standard of care. And when parents choose not to bring their children for any well care or refuse to immunize their children, that is neglectful. But as with other forms of child abuse, we have to know what the law says. And the law in the state of Wisconsin does not require parents to bring their children to a provider for well child care, and the law does not require parents to immunize their children. It is strongly recommended, but it is not legally required. Now, why is it that children don't get the care that they need? What I've found in these circumstances is that it's critical to determine if the parent understands the reason for the care that's recommended by providers. It's critical to determine if the parent understands the potential risks and benefits for compliance and non-compliance with recommended medical care. Sometimes we as providers think we're very clear and that we've explained things really well, but then we come to find that we actually didn't do such a great job, or that the way we explained it made absolutely no sense to the parent. So the other thing that's really critical in these cases is to try to understand the parent's beliefs regarding the recommended care. It may be very obvious to you as a provider that a certain type of seizure disorder requires a very specific anticonvulsant. Culturally, or just medical beliefs of the family may be that that medication, for whatever reason, is going to actually harm their child. They may believe that the medication is going to take their child's personality away, or it's going to cause some other problem, which they see as much more serious. And so they can't imagine giving that medication. But they may not realize that you don't know they believe that. It's critical to have cultural sensitivity anytime there is a discrepancy in compliance with recommended care. And it's important to try to find some common ground as a place to begin and plan to have a discussion with patience, kindness, and good listening skills on our part. Poverty certainly may play a role in noncompliance. Sometimes it's a matter of money. The parent can't pay for the medication you've recommended and may be uncomfortable telling you that. Perhaps they don't have the ability to get to the store where the medication could be purchased. Perhaps they live in an incredibly chaotic environment, and the ability to administer medication to a young child consistently twice a day is way beyond that parent's capabilities given their day-to-day, hour-to-hour life circumstances. And so again, trying to understand where the barriers are will help you to be able to try to problem solve with the family and result in the child getting the care that they need. So, in summary, medical child abuse is a form of child maltreatment and occurs when a child receives unnecessary and harmful or potentially harmful medical care at the instigation of their caretaker. There is a range of severity, which may or may not escalate over time. The diagnosis is often difficult and frequently delayed. Early involvement of a child abuse pediatrics team is extremely helpful in these complicated cases. And intervention follows the same format as other types of child maltreatment, with the safety of the child being central to the concern. And here are a list of some references for you if you want to read more about it. Okay, I can take more questions if there are any.
Yes, a couple questions. Do you have any resources for sane RNs dealing with parents requesting multiple repeat sexual abuse exams with accusations against the other parent that continue to be unfounded? CPS is already involved with each case because of the mandated reporting laws.
I think that I've actually also had that experience in my own practice. And I think in the case of sane nurses, contacting the child's primary care physician or your child abuse pediatrician that you work with and scheduling a meeting where that provider sits down with the family, reviews all of the times they've brought the child and the findings, and then what the harm is to the child to continue to do this, meaning continue to have repeat exams, is a critical, lengthy discussion that needs to be had. And I encourage it to be either their primary care provider or the child abuse pediatrician, because you then have one point person that they can contact when they have their next concern rather than just walking into the ER for an exam. So it needs to be discussed. They will need lots of reassurance. They will need lots of time to process. And then they will need to have someone they can follow up with. Sometimes a behavioral health provider is also very helpful because they can help the parent develop some coping skills for the next time that they think they're seeing things that aren't there.
They said, thank you. We have been in contact with our Child Advocacy Center, but should probably meet. Another question, if they start a series of vaccinations, is it legally required for them to finish the series or set? Example, only received 2 of 5.
No, there is no legal requirement in the state of Wisconsin to do any vaccines. Now, schools may have requirements for admission, but as far as, the legality of doing or not doing vaccines, they can stop at any point.
Thank you. Another question, if there are flags and the family has moved around a lot, how easy is it to find and get the medical records from past doctors?
It takes a lot of time and a bit of detective work. If you're lucky, you have support staff that you work with that becomes very adept at this. And sometimes you get one set of records, and through reading those, you figure out where they were before that. Or, it can be very, very time consuming and challenging, but it can be done.
Great, thank you. That's all the questions we have for now.
Okay.
I'll ask you to leave the attendance slide on the screen for a couple of minutes.
Sure.
Attendees, if you have not already done so, you may now text the attendance code and complete your evaluation. Please join us for next month's webinar, Status of Safe Sleep in Wisconsin, presented by Dr. Judy Walczak. Thank you for being with us today.